Hello everyone, hope you're all doing good. This is Dr. Agalya from the video. In this video, we're going to continue with the discussion of abnormal uterine bleeding, right? So, abnormal uterine bleeding. So, I hope in the last section itself we have discussed about the various causes of abnormal uterine bleeding, especially the POM coin classification, right? So, we are going to discuss about the various contents of that POM coin classification. Okay, so this is what we have discussed. So let's start discussing each one individually now, right? So let's start with polyp. In polyp, there can be prolonged uncontrolled bleeding or intermenstrual bleeding, pallor, or sometimes they can also present as cases of infertility. When you examine, the uterus is normal in size. Suppose if the uterus is big and the os is patulous, suppose if the uterus is big and the os is patulous, then this polyp can be seen extruding outside through the os. Okay, and here the endometrium will also be thickened. Okay, so this is how the uterus will be in polyp. And the various investigations we can do for a polyp include your saline infusion sonography, where you will be able to see this polyp as an echogenic mass. Also, it will be a smooth intracavitary mass that is outlined by fluid. In ultrasonogram, you will be able to make out the polyp as a single mass that is protruding into the cavity with a feeding vessel. Okay, so this is important, a mass with a feeding vessel sign. Okay, so this is how it will be looking. Okay, if you see, this is the endometrium, whereas this is the line of endometrium. Okay, but in the line of endometrium, you are getting the vessels. Okay, so the color Doppler is showing the vascularity of that particular region because a mass is protruding inside, which is nothing but a polyp. Clear? Right. Let's go on to the next one of POM, that is adenomyosis. Okay. In adenomyosis, there can be heavy menstrual bleeding or there can be marked dysmenorrhea also. Here, the uterus can enlarge up to 12 weeks. And remember, the uterus is uniformly enlarged here, and tenderness can be present or absent. There can be thickening of the uterine wall, which can be asymmetric in a focal disease. Okay, and it will be obscuring the endomyometrial junction. So here there can be multiple hypoechoic halo zones of more than 12 millimeter thickness that can be seen, and sometimes you will be able to make out also the heterogeneous texture of the endometrium. Clear? So this is all about adenomyosis. So you will be having heavy menstrual bleeding, then there will be marked dysmenorrhea. The uterus will enlarge up to 12 weeks in size and it is uniformly enlarged. Tenderness can be present or absent, and there will be thickening of the uterine wall that will be obscuring the endomyometrial junction, and on scan you will be able to visualize the multiple hypoechoic halo zones which will be more than 12 millimeter thickness, and heterogeneous thickness of the endometrium can also be noted. Clear? Right. Now, let me show you a specimen of adenomyosis. Okay, so this is a specimen of adenomyosis where you are able to see the endometrium and there is hypertrophy of the myometrium, and there are many tiny cystic spaces, okay, that is representing these tiny cystic spaces. Okay, so these are representing the endometrial glands. Okay, so this is adenomyotic uterus. Clear? Right. Now, next one is about the leiomyoma. Leiomyoma can be a submucous one where there can be more prolonged uncontrolled bleeding, or it can be an intramural one where there can be variable amount of heavy menstrual bleeding, and sometimes it can be a subserous leiomyoma also, but most of the times the subserous leiomyoma is asymptomatic. Okay, and generally in leiomyoma the uterus is irregularly enlarged and firm. There is globular uterine enlargement, thickening of the uterine wall, which may be asymmetric in focal disease. Definitely, there can be obscuration of the endomyometrial junction, and multiple hypoechoic halo zones more than 12 millimeter thickness can also be seen. Okay, and definitely as we have seen in adenomyosis, there can be heterogeneous texture of endometrium as well. Clear? So these are the ultrasound features you will have in fibroid. Okay, there will be thickening of the uterine wall, it will be asymmetric in focal disease, there will be obscuration of the endomyometrial junction, there will be multiple hypoechoic halo zones which will be more than 12 millimeter in thickness, and there will be heterogeneous texture of the endometrium as well. Clear? Now, let's see about malignancy, that is the M. So, this can present as post menopausal bleeding, irregular bleeding, that can be seen especially at the perimenopause. Then here you have normally to mildly enlarged uterus which has a thickened endometrium. Especially we have to be worried when the thickness is going more than 4 millimeter in postmenopausal women and it is going more than 12 millimeter at the perimenopausal age group. Okay, so this is for the perimenopausal age group and this is for the postmenopausal women. Clear? Anyhow, that category will be going for postmenopausal bleeding, but I am just letting you to know the cutoff here. Okay? Yes. Here, USG features can show endometrial hyperplasia, there can be thickened endometrium, then there can be irregular endometrial linings and loss of endomyometrial junction. Clear? Now, we will discuss about coagulopathy. Okay, so coagulopathy can happen during puberty. Menorrhagia will be there. Okay, in this set there will be menorrhagia or heavy bleeding at menarche. There can be a history suggestive of bleeding diastasis or there can be a family history, and in these cases the uterus is going to be normal size. There is pallor, easy bruisability and even petechiae. Okay, and sometimes when you do a ultrasonogram, you may be able to see hemorrhagic cyst in these people. Okay, especially hemorrhagic cyst in the ovary. Okay, so these are the things we have to consider when they are a case of coagulopathy. You have to ask about their pubertal history, whether there was menorrhagia at the puberty, what about the bleeding at menarche, and there is any history that is suggestive of bleeding diastasis, there is a family history. You have to ask for their, you have to examine and look for their uterine size, and you have to also ask them if they are susceptible for easy bruisability or petechiae. And ultrasonogram in these patients may sometimes even show hemorrhagic cyst in the ovary because there is bleeding tendency. Okay, so even a cyst can bleed. Okay, so that will be presenting as a hemorrhagic cyst in the ovary. Clear? Right. Now, let's now discuss about the ovulatory disorders as such. Okay, ovulatory disorders. Okay, so let's see this. In these patients, there will be signs of anovulation or They can present with polycystic ovarian syndrome features. There can be oligomenorrhea or insulin resistance. Okay, and on examination, the uterus is normal size in these people, and on ultrasonogram you will be able to see polycystic ovaries and thickened endometrium. Clear? Right. Next one is, let's see about the endometrial conditions. You will have intermenstrual spotting or even a prolonged bleeding can be there. Okay, there can be discharge per vaginum or even cervical erosion. Okay, here the uterus is normal size and you will also have fluid in the endometrial cavity. Clear? Next one is iatrogenic causes of, okay, so iatrogenic causes will include history of medications, we have to ask medication intake. Also you have to ask about the copper T usage. Okay. Usually there will not be any uterine abnormality, any change in the size or like that in these people, and on examination you may find copper T inside. Okay, will you do a USG? Clear? And there are something called as not otherwise classified group. So not classified group means they will include the heavy menstrual bleeding, okay, and you have to offer them other investigations like uterine ultrasonogram, Doppler, or you have to even rule out arteriovenous malformation, etc. Clear? Right. So this is all about the expansion of sperm coin. We are done. Okay. Now let me tell you why this bleeding is happening. What is the pathophysiology? Why suddenly this AUB has to come? Okay. For this, we have to go a little bit into the anatomy and the physiology so that you will be understanding the pathophysiology of AUB. Okay. Pathophysiology of AUB. Okay. So we know the uterine arteries, okay, the uterus and ovaries are supplied by the uterine and ovarian arteries. Okay. Then these arteries are going to become the arcuate arteries that will send off radial branches. Okay, that will be supplying blood to the two layers of the endometrium. Okay, so what are the two layers of endometrium? Yes, we have the functionalis layer as well as the basalis layer. Clear? Right. Now, what happens means progesterone falls down at the end of menstrual cycle. So, when progesterone levels are falling down, this leads to enzymatic breakdown of the functionalis layer of endometrium. So, soon after this breakdown, there will be blood loss, sloughing. This will lead to menstruation. This menstruation will be controlled by the functioning platelets, thrombin and vasoconstrictors that are secreted. Okay, so they will be constricting the arteries. So this will be controlling the bleeding. Okay, so that means controls the menstrual blood loss, in other words. Okay, so any derangement that is happening in the following features. Okay, say in the structure of the uterus, that can happen due to fibroid, endometriosis, adenomyosis, polyp, or even hyperplasia. Okay, and yeah, obviously malignancy also. Okay, then any derangement in the clotting pathways. Okay, that includes coagulopathies or any iatrogenically introduced drugs that will be disturbing the coagulation system, or there is disruption of hypothalamic pituitary ovarian axis. Okay, so that will be leading to ovulatory or endocrine disorders, and sometimes this can also be brought about by iatrogenic causes. Okay, so all these disruptions or derangements can lead to uterine bleeding. Clear? Right. Now, let's start knowing what are the investigations as such you have to offer to your patient with abnormal uterine bleeding. Okay, so the investigations will include serum or urinary beta HCG. Very important thing is to rule out pregnancy in these patients. Okay, very important. This is the first and foremost thing you have to do. Okay, then do a complete hemogram that will tell you about the degree and type of anemia. You have to do a screening for coagulation disorder. So, screen for coagulation disorder, that should include complete blood count, platelets, prothrombin time, partial thromboplastin time, and screening for von Willebrand disease. Okay, screening for von Willebrand disease. Clear? Then you have to prepare a wet preparation if there are more cervical secretions. Okay, you have to check the chronic cervicitis or infection. Then don't ever forget to offer them other investigations, okay, that should check their endocrine function. Okay, that will include thyroid stimulating hormone, testosterone, prolactin, and gonadotropins. Okay. Finally, investigations like ultrasonogram should be offered. It can be a transvaginal ultrasonogram. You can offer them Doppler as well, and saline infusion sonography can also be given. Okay. And finally, endometrial biopsy can be offered by a People's aspiration. It can also be done as a hysteroscopic guided procedure. Okay, and remember, this is considered to be the first line of investigation in more than 45 years of age. Okay, whereas in less than 45 years, since it is an invasive procedure, we are offering it only when she has obesity or polycystic ovarian disease, or when the endometrial thickness is more than or equal to 12 mm. Clear? Right. And also you can offer MRI in some patients. Remember, don't offer CT, offer MRI, because MRI is superior than CT, and then it will also help you to differentiate between adenomyosis and endometriosis. Clear? Right. Okay. Now, we are going into the most important part of AUB. We are going to discuss about the management of abnormal uterine bleeding in detail. Okay. We'll be using hormonal supplements or non-hormonal agents, some minimally invasive procedures, and finally the surgeries which can be offered. Right? So, let's start with the hormonal agents used in abnormal uterine bleeding. So, the hormonal agents that can be offered include your conjugated equine estrogen. Okay, so this is conjugated equine estrogen. Okay, so the dose of this drug is 25 milligram IV every 4 to 6 hourly, that can be given for a period of 24 hours. Okay. Contraindications of using this drug are mostly pregnancy, when she has a history of thromboembolic disorder, or she has a history of breast cancer. Okay. And what are the adverse effects? What are the adverse effects? Adverse effects will include nausea, headache, mastalgia. There can be breakthrough bleeding, thromboembolism. Okay, there can be CVA also. Okay, So this is all about conjugated equine estrogen. You have to know the dose, you have to know what are the contraindications and what are the side effects. Okay. So this is the first drug we have seen. And the second one, we'll see combined oral contraceptive pills. Okay. So combined oral contraceptive. So here the dose is for acute conditions, you can give them monophasic pill that is containing a 35 microgram estrogen 3 times daily for 1 week. Okay, this can be followed by once daily for 3 weeks. Okay, so 1 week and 3 weeks. Okay, and what are the contraindications? So contraindications, there are so many contraindications. I am listing you only a few of the important one. It is contraindicated in pregnancy or when there is a smoking history, breast cancer history is there, or there is liver disorder, stroke, valvular heart disease, APLA, SLE, diabetic nephropathy, like that. Okay. So in all these causes, you have to think before giving your combined oral contraceptive pills, right? So what are the adverse effects of using these drugs? Again, yes, there can be nausea, headache, mastalgia, breakthrough bleeding. The same thing applies here also. Thromboembolism, CVA and ischemic heart disease. Clear? Right. And sometimes instead of offering combined oral contraceptive pills, we can even offer them a simple oral progesterone. Okay. So oral progesterone. Here the dose is medroxyprogesterone acetate that can be given at a dose of 20 milligram 3 times a day for 7 days. Okay. Contraindications, pregnancy, liver disease or liver tumor, breast cancer or ischemia heart disease. And then adverse effect of using progesterone drugs include irregular bleeding. Clear? Yes. We can also offer them levonorgestrel intrauterine system. So here the dose, it's not about the dose. The thing is, it cannot be given when she is having acute bleeding. But the advantage of this is it can be kept for a period of 5 years intrauterine, and yeah, daily it will be releasing progesterone at a dose of 20 microgram daily. Clear? And what are the contraindications? Contraindications of this drug, of levonorgestrel IUS include pregnancy, unexplained vaginal bleeding, liver disease, cancer cervix, breast cancer. There is uterine abnormality, or there is a history of STI within 3 months, or there is pelvic inflammatory disease, right? Let us discuss about the adverse effects of using levonorgestrel IUD. So, adverse effects can include nausea, mood disturbances, acne, spotting, mastalgia, sometimes pelvic cramps are also clear, right? Then it is depot medroxyprogesterone acetate. Okay, so DMPA, which is nothing but depot medroxyprogesterone acetate. So this drug is given as an IM injection at a dose of 150 milligram every 3 months. Okay. So the contraindications of giving this injection include pregnancy, when there are multiple risk factors like cardiovascular disease, okay, when they are elderly, diabetic, okay, or she is a known case of hypertension like that, okay. So in that case we have to avoid. Then obviously we have to avoid giving it during breast cancer, ischemic heart disease, or liver disorders, or she had a history of stroke. Clear? Then let us discuss about GnRH, gonadotropin releasing hormone. Especially we are going to discuss about the leuprolide acetate. Okay, leuprolide acetate in heavy menstrual bleeding will be giving at a dose of 3.75 milligram IM as a monthly injection, or 11.25 milligram IM that can be given every 3 months. Clear? So the contraindications of giving this drug include pregnancy, and if you ask me what are the adverse effects, there can be symptoms of menopause, okay, menopausal like symptoms, like there can be hot flashes, vaginal dryness, like that, okay. So, and this happens especially when this drug is used for more than 6 months, okay, more than 6 months, okay. So that we should be much cautious. Clear? Let's see about danazole. In heavy menstrual bleeding, danazole is given at a dose of 100 to 400 milligram orally daily, or it can be divided into multiple doses also. And the contraindications of giving this drug include pregnancy, unexplained uterine bleeding, and there are impaired cardiac, liver, renal functions as well. Okay. So what are the adverse effects? Okay, adverse effects of this danazole. Okay, so that include weight gain, there can be androgenic side effects, acne, and there can be blackening of skin also. Okay, so this is all about hormonal treatment of AUB. Okay, so that's all we have discussed. So to summarize, what and all we have discussed under hormonal treatment of AUB, we have discussed conjugated equinated estrogen, then combined oral contraceptive pills, then we have discussed how to give oral progesterone, then also about giving levonorgestrel, IUS, your DMPA, yes, then GnRH analog, which is your leuprolide acetate, and finally we have also discussed about dianosol. So all these things are nothing but the hormonal agents that are used in the treatment of AUB. Clear? Right. Now, let's see some of the non-hormonal agents that are used for treating AUB. Okay. So, non-hormonal agents in AUB. Okay. The first one is tranexamic acid. Dose of tranexamic acid is 1.3 milligram orally, that is given every Q8th hourly for 5 days. Okay, it is usually given in ovulatory women with AU. Okay, so what are the contraindications? Contraindications of tranexamic acid include if she has a history of thromboembolic disorder and there is impaired color vision. Okay, and remember, when there is impaired color vision, tranexamic acid should not be this tranexamic acid should not be combined with combined oral contraceptive pills. This combination also should be avoided. Clear? Right. Now, let's see about the adverse effects. Adverse effects include nausea, vomiting, diarrhea, and then myalgia. Clear? Right. And the next non-hormonal agent used in the management of AUB is NSAIDs. Okay, non-steroidal anti-inflammatory drugs. We can give ibuprofen. Okay, ibuprofen at a dose of 600 to 800 milligram. Okay, and this is contraindicated in pregnancy when there is a history of gastrointestinal hemorrhage, bowel disease, renal disease, asthma, like, okay, and this drug is given every Q6 to 8 hourly. Okay, so why we are avoiding it in gastrointestinal disorders or any hemorrhagic disorders? Because the side effects of the drug include bleeding, ulceration, perforation of gastrointestinal tract, and it alters the platelet function and this can increase asthma. Okay. Now, let us discuss about the surgical management. Surgical management of AUB include so many minimally invasive procedures and major procedures. You can do dilatation and curettage. Okay, this removes thickened endometrium that is causing bleeding. Then you can offer endometrial resection or endometrial ablation. So that removes and destroys the endometrial lining permanently by using either thermal, electrical, radio frequency or laser energy. Okay, and we have the indications of doing endometrial ablation. So indications of doing endometrial ablation include when there is resistant to medical treatment, there is no plan for future childbearing, uterus is not more than 10-week size, and if fibroids are present, they should be less than 3 centimeter. Okay. Now we have so many methods of endometrial ablation, and they are actually classified into first generation and second generation procedures. Okay. So the first generation procedures actually had TCRE, that means transcervical resection of the endometrium, or there was roller ball coagulation, resection using a wire loop, or even a laser. Okay. Here we are able to see, yes, this is transcervical resection of endometrium. Okay, so through the cervix you are entering a resectoscope and you are going to dissect the endometrium. So you are able to see the instrument here, right? And this is a ball-like configuration. This is a roller ball electrocoagulation, which will be having a ball-like thing, and it will be rolling over the endometrium and coagulating it. Okay. Now, the second generation endometrial techniques include hydrocoagulation, that is using a thermal balloon, or cryosurgery, or using radio frequency, etc. Right? Now let's discuss about the results of ablation therapy. Okay, so the results of ablation therapy, here 40% become amenorrheic and 40% they will improve. Okay, show significant improvement, and then 20% does not show any response. Clear? Right. Let's also discuss about the complications of using endometrial ablation techniques. Yes, there can be uterine perforation, then chances of infection, increased risk of hemorrhage, and formation of hematometra as well. Clear? Now, apart from this technique, you can also go for something called UAE. Okay, that is uterine artery embolization. Okay, So this is mostly done when it is associated with Leiomyoma, and it is done usually as an emergency procedure in acute heavy menstrual, okay, and sometimes it can also be offered in heavy menstrual bleeding that is showing no response to conservative technique. Clear? So this is about uterine artery embolization. And the next one is, you can even go for uterine tamponade. Uterine tamponade can be given using a Foley's catheter that is introduced and inflated with 30 ml of fluid, okay, and this should be kept for a period of 24 hours to arrest the acute episode of bleeding. Clear? And the major surgical procedures you can offer the women with AUB include myomectomy. Okay, so usually the indication for myomectomy is a large fibroid with pressure symptoms, and one important aspect is the woman wants to conceive. Okay, that means the family is not yet completed in that woman. Okay, and the next one is hysterectomy. Hysterectomy, usually it is not advised as a first line therapy. Okay, not advised as a first line therapy. Usually it is discouraged because there are wide non-invasive methods, medications, hormonal, non-hormonal agents, etc. Okay, and so this is usually given when there is failure of medical and other procedures, when she has completed family and she is going to be more than 40 years of age. Clear? Yes. So this is all about the management of heavy menstrual bleeding. Okay. To conclude, I want to include one last point on AUB, that is how we will be classifying AUB according to the age. What are the expected causes of AUB according to the age group of a woman? Okay. So according to the age group, in childhood, the causes of AUB include trauma, foreign body, malignancy, and vulvovaginitis. Okay. Second one is, in adolescent age group, there can be chances of anovulation or coagulation disorders. Okay. Coagulation disorders, especially von Willebrand disease, right? And the next one is reproductive age group. There can be chances of fibroid, pregnancy, or polyp. And during perimenopause, there can be chances of anovulation again, or any benign growth, or even malignancy. Okay. Then finally, Menopause can be due to atrophic endometrium, endometrial cancer, then vulval, vaginal or cervical lesions as well. Okay. So, yeah, we are completing AUB, a big topic and confusing topic in gynecology. I hope this video would have helped you. And until we meet in the next video, take care. Happy learning. Bye bye.